Hello and good evening, everyone. Welcome to our 13th Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. This platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. I am going to be your host, Adam Getachew, the co-founder and CTO at Blue Health Ethiopia, and we are honored to have Dr. Bekkala Alemayo here with us. He's going to give us an update on the approach and management of myocardial infraction. I don't think Dr. Bekkala needs an introduction, but to give you a little bit introduction, Dr. Bekkala is a pioneer interventional cardiologist in Ethiopia, and he is also a local trainee to implant pacemakers, the first local trainee to implant pacemakers. And he has also worked in Addis Ababa University as a lecturer, assistant professor, associate professor of medicine back in 1999. And he's a founding member and lead physician at Gambia Hospital for 3 years. And he has also worked as a founding member and lead interventional cardiologist at this cardiac hospital for the first 10 years. And currently, he is the founder, owner, and current lead interventional cardiologist at Gesund Cardiac and Medical Center. He has been awarded outstanding contribution to cardiovascular service in training in Ethiopia by Ethiopian Society of Cardiac Professionals in 2019. And he has published more than 20 research and publications. I think this is a little bit introduction about Dr. Bekkala. Dr. Bekkala, the stage is yours. You can unmute and continue.
Thank you very much. In the coming 45 minutes or so, I am going to outline the management of acute coronary syndrome in general. And the emphasis will be, given my profession and dedication, the emphasis will be on revascularization, obviously. First of all, why do we worry about cardiovascular diseases in general? Cardiovascular diseases, we know that they have been number one cause of deaths across the globe since 2001. That was the first time we knew cardiovascular diseases are number one killers across the world. And according to WHO, in 2015 alone, 17.7 million people have died because of cardiovascular disease. And this figure represented 31% of all the global disease, 7.4 being from coronary artery disease, 6.7 from stroke. And on the other hand, the other way of looking at it, when premature cardiovascular deaths because of non-communicable diseases was considered, there were around 17 million premature deaths, that means deaths before 70. And of this, 82% existed in low and middle income countries. And this was caused, like cardiovascular disease, caused 37% of this. So that means cardiovascular diseases, when the premature deaths were considered, it was the percentage was a little higher than the total deaths. To just show you the trend over the last decades, like according to the Global Disease Burden Study, between 1990 and 2013, there were changes of cardiovascular mortality, like because of population growth, there was an increment by 25%, and because of population aging, there was an increment by 55%. Whereas epidemiologic changes, that means better treatment of coronary artery disease and other cardiovascular diseases, has contributed a reduction by 39%. But altogether, overall, there was an increment between these 2 years, by an increment by about 41%. And roughly 50% of the total cardiovascular diseases are because of coronary artery disease alone. And when it comes to our situation, our practice settings, this is a data out of Addis Cardiac Hospital, the first 5 years. In the first 5 years, those patients or individuals who have visited Addis Cardiac Hospital, like 22% of them had either typical or atypical angina. That means the diagnosis being most likely coronary artery disease. And in those individuals who have visited that hospital, by the way, there were around 32,000 individuals. And of these, 41% had either dyspnea and or orthopnea. The implication is heart failure, mind you. So unrecognized events and situations presenting with heart failure is a common encounter in our practice patterns. And this is to just put it in terms of etiology from data analysis. Coronary artery disease was the second most frequent cardiovascular etiology diagnosed, just preceded by hypertension with hypertensive heart disease only. And this is our current data from Gesund Cardiac Hospital, whereby we have analyzed the first 197 patients that have undergone PCI over the first 2.5 years. And of those, 76% presented with typical angina. Dyspnea and orthopnea existed in some 50% of cases. This is again the implication of these are totally, fully diagnosed, established coronary artery disease cases. And of this, the implication of heart failure goes up to 50%. Now, how do patients with coronary artery disease present? Like, it's not acceptable to write down at the end of a case analysis, one cannot write down ischemic heart disease. It has to come in one of these 4 scenarios. The first is stable coronary artery disease or chronic coronary syndrome. And the second is acute coronary syndrome. That means with a constellation of unstable angina, non-ST elevation MI, and STEMI. The third is heart failure. These are patients without recognized former cardiovascular events, ischemic events not being recognized. They present in a state of heart failure. And the fourth presentation is malignant arrhythmia or sudden death. The most unfortunate ones come with the fourth diagnosis or the fourth scenario. So now to come to acute coronary syndrome, as I presume that everybody knows, acute coronary syndrome is a spectrum of conditions from stable angina, non-ST elevation MI, up to ST elevation MI. The difference between unstable angina and others is troponin positivity, whereas the difference between STEMI and NSTEMI is significant ST segment elevation in the case of ST elevation MI. With regards to the epidemiology of acute coronary syndrome, both MI in general as well as STEMI are on the decline because of better management of risk factors and treatments like intervention, whereas non-ST elevation MI is on the rise. Roughly stable, but tendencies towards increment. And this is believed to be because of better treatment of conditions and better survival longevity of patients, so that they would have time to develop multiple coronary bed involvements leading to formation of collaterals, preventing transmural MI or ST elevation MI. So the condition becomes skewed towards non-ST elevation MI. An additional factor that contributes is better diagnosis of MI through high sensitivity troponin is also contributing to this fact. When it comes to our circumstances, like in our patients, those 197 patients which have undergone PCI with a definite diagnosis of coronary artery disease, some 56% of them were visiting our hospital because of STEMI, followed by chronic coronary syndrome, usually typical angina with plus angina equivalents, and it was around 37%, whereas STEMI was contributing less. When it comes to the pathophysiology of coronary artery disease, particularly acute coronary syndrome, like if you look at the middle, this is a plaque with overlying cup, with fibrous cup, and this is a plaque proper. So it can go either to plaque rupture in the situation of acute coronary syndrome, leading to complete occlusion of the arterial lumen, and leading to ST elevation MI, or there might be, without any gross communication between the luminal melee and the plaque proper, there will be denudation of the endothelium, leading to thrombus formation over the fibrous cup, which is known as plaque erosion. These are the two common forms of pathophysiologic coincidences in patients with acute coronary syndrome. So this situation happens when the plaque becomes vulnerable. Coronary artery disease runs in crisis, like it becomes settled, and in situations of uncontrolled biochemical circumstances, the plaque becomes unstable. And the features of unstable plaque are: one, thin fibrous cup. The fibrous cup, the overlying cup, becomes thinner when it becomes unstable. It becomes lipid rich. The core becomes full of lipids, and the number of inflammatory cells increases. There will be neovascularization and intraplaque hemorrhage, because these new vessels that develop within the plaque are very fragile, so they are very liable for hemorrhage. And then there will also be microcalcification, or this is what is known as punctate calcification, and the number of smooth muscle cells becomes decreased. That is the reason why the fibrous cup becomes actually thinner. And this is because when the number of inflammatory cells is huge within the plaque, like for instance, T cells will elaborate interferon gamma, which inhibits smooth muscle cells from producing collagen fibrils. And on the other hand, these stimulated or activated T cells would also elaborate CD40 ligand, which activates the macrophages directly, in effect eliciting increased amount of matrix metalloproteinases. So on one hand, the production of collagen fibrils is reduced, and on the other hand, there is increased degradation of the collagen fibers, or the connective tissue, the overlying tissue, but that harbors, facilitates the situation towards very instability and eventually creation of ischemic events. So now, in managing patients with acute coronary syndrome, first of all, what is our goal? The first goal is treatment and prevention of complications, and the second one is to minimize myocardial damage. So we should prevent complications like electrical as well as mechanical complications. And on the other hand, one has to, from the time that he or she contacted a patient with acute MI, must target to minimize myocardial damage. And this is achieved through the chain of survival. The first one is earlier contact, like the emergency medical team has to be contacted very early. If you take, for instance, our situation, it is very difficult and to achieve optimal situation in this circumstance. But I think our health education and everything should work hard to sensitize the society towards early detection of alarming symptoms. And the next is efficient practice, especially to shorten door to reperfusion time. And this is achieved within the hospital. Once we have contacted these patients, we should immediately triage them, like if there is a possibility of intervention, for example. And the next is within the cath lab, prompt implementation of reperfusion with well-trained team is another critical issue. So when it comes to the role of emergency medical systems, you know, it's very critical. The emergency medical system is very critical in achieving two goals. One is one has to cost effectively identify the 15 to 30% of genuine cases of acute coronary syndrome out of the total acute coronary syndrome looking patients. And the next important issue is, you know, detection of other life-threatening situations like aortic dissection, pulmonary embolism, cardiac tamponade, and esophageal rupture has to be made at that point. So because of this, the early contacting emergency medical system is very critical in the management of acute coronary syndrome. How do patients present in situations of acute coronary syndrome? Mostly, it can be identified by history and ECG. A combination of chest, upper extremity, mandibular, and epigastric discomfort, or ischemic equivalents like dyspnea, fatigue, and syncope are the presentations. So then, if there is a high index of suspicion, one cannot or one would not be liable to miss the diagnosis of acute coronary syndrome, particularly MI. The central point with regards to the diagnosis of MI is troponin. Troponin is a preferred biomarker because it exists almost exclusively in the heart. This is limited to troponin T and troponin I, while troponin C is also prevalent in skeletal muscle, so it's not specific enough like that of troponin I and T. So troponin C is not part of it. And high sensitivity assays are currently recommended, and they are well validated. And then the diagnostic limit, like 99 percentile of the upper reference limit, has to be met to make a diagnosis of acute coronary syndrome, MI. Then troponin elevations could be because of several causes. The mere presence of troponin positivity does not make a diagnosis of acute MI. The first one is like when there is a rapid rise and fall, the classic situation is acute myocardial infarction, being type 1, type 2. These are according to the universal definition of acute MI. There are several categories, up to 4 or 5. And type 1 and type 2 are classically the classic, they display the classic rise and fall of troponin. The other situations that may confound themselves with a rise and fall are acute heart failure and myocarditis, but situations like injury, chronic injury of cardiac myocardial tissue with structural heart disease or chronic kidney disease, they just display troponin elevation in persistency. So to coin a diagnosis of acute MI, as I said earlier, central point is troponin, plus either typical symptoms or relevant ECG changes or a new regional wall motion abnormality displayed, for instance, with echocardiography. If we have one already done before, and if we detect a new one, then that can settle the diagnosis of acute MI, or demonstration of a thrombus in the cath lab with angiography, or the unfortunate ones would be diagnosed to have MI at autopsy. In the early management of acute coronary syndrome, particularly MI, the setting should contain the following things. One is there should be a facility for proper defibrillation. Second, there must be, the circumstance should have high flow oxygen, IV access, available ECG, continuous ECG monitoring, medications like nitrates, aspirin, clopidogrel, maybe plus minus beta blockers would be necessary. And the third, the setup, the manpower profile should be able to detect and manage complications like recurrent ischemia, arrhythmia, and heart failure. If this is met, acute MI can be managed anywhere. With the next issue, the next point is, proper administration of antithrombotics, particularly the heparins, where low molecular weight heparin is chosen for conservative management, whereas unfractionated heparin is dedicated for interventional management, and others like fondaparinux or bivalirudin are substances to be used in conservative and interventional, are alternatives for conservative and interventional management respectively. Let me just show you a case. This is an individual who visited our hospital, Gizund, a week ago. He came from Ambo, a 65-year-old male, diabetic and hypertensive, presented with the squeezing chest pain of 1 day duration when he presented to Ambo Hospital. And the blood pressure by then was 200 by 100. But when he appeared after he was properly managed with aspirin, clopidogrel, heparin, and enalapril was administered for the very high blood pressure. And subsequently, when he started to move from Ambo to Addis, he was requiring 1 to 2 liters of oxygen. But because of the distress of the transfer might have contributed, when he came here, he was requiring over 10 liters of oxygen via face mask. Then, the echo revealed anteroseptal and apical hypokinesis with ejection fraction of 30%. And overnight, we just focused on we just continued medications like the antithrombotic. Enoxaparin was continued, aspirin and clopidogrel were continued, but the focus was proper diuresis. After a proper diuresis in the morning, he was just requiring a liter of oxygen, and we could comfortably take him to the cath lab, and we found out this finding. It seems to be okay. Like, for instance, there seems to be a very good, maybe if interventional cardiologists are around, there seems to be a good landing zone at the just distal to the ostium of the ostial lady. But unfortunately, this is a realistic picture. You see, this is a small marginal branch from the circumflex. Otherwise, the lesion starts just from the left main with classic ostial manifestation. Then we started to work on it. This is ballooning. And then after the balloon, the artery is fairly opened, but still it requires further look. This is when it was being stented. And this was the final result of that particular individual. So now, what about? Now let's just focus on acute coronary syndrome. Dividing the management of acute coronary syndrome is divided into non-ST and ST elevation. When it comes to non-ST elevation MI, that means composing both unstable angina and non-ST elevation MI, the issue of revascularization is complicated by whether it's universally applicable or selectively applicable. That means invasive versus ischemia-guided strategy is critically important, unlike STEMI, whereby everybody should be intervened whenever possible. So the advantages of early intervention in non-ST acute coronary syndrome are: one can rapidly define the problem through characterization. Two, early revascularization could prevent further complications, and facilitation of earlier discharge is an advantage. And then it can be applied as early or delayed invasive. You know, when these two strategies were compared, the complication rate or the event rate was barely better with invasive strategy as a whole, when the entire spectrum of patients was considered. But when that was divided risk-wise, low risk, intermediate risk, and high risk, the difference seems to be limited to those individuals with high risk. And this is a constellation of DAISY and MI that seems to be very different between invasive and non-invasive strategy in high-risk patients. So, in conclusion, routine invasive strategy does not reduce all-cause mortality, and it may increase complication rate, but it reduces composite ischemic endpoints. That means recurrent MI, recurrent ischemia. And unfortunately, these studies are done before the radial access that has improved the circumstances. Modern drug-eluting stents, the third generation drug-eluting stents was zotarelumis and the others. Complete functional revascularization, meaning FFR, the application of FFR, has been able to select out lesions that genuinely require intervention. And modern dual antiplatelet therapy has also mitigated the situation. And intensified lipid therapy had also its contribution. And contemporary biomarker assays have also improvised on this situation. So in these circumstances, in the presence of these issues, I think these studies, they need to be repeated. Let me take you to one of our patients who presented as a case of demanding unstable angina. This is a 72-year-old diabetic and hypertensive male who presented with typical angina of 2 years. And in the last 1 month, the angina deteriorated to be precipitated just by a few meters of walk while he was taking aspirin in the high-intensity statin, because he visited even a cardiac setup. This is an angiogram. There is a tight stenosis along the mid-distal circumflex. You can see this. And then the LAD is totally occluded here, right after this diagonal branch. And there is a collateral ascending up. RCA is like this. This is classic cerebral disease. It's very tight stenosis at the mid-RCA. Then we started working on it. We chose to intervene first on the RSA. This is because RSA is somehow a type A lesion, which is amenable to PCI. And that's the most important vessel to him. LAD is totally occluded, and the circ is a distal lesion. But this one is very proximal. If it is occluded, it is very detrimental. So the end result was like this. Then we moved immediately to the left, and we did first the circ. Then we started the most difficult one, the LAD total occlusion. This is, this is after it has been wired and ballooned once. after stenting, this was the result. Now, let me take you to STEMI. What makes STEMI different from the rest of the acute coronary syndromes is it should be offered immediate reperfusion therapy in either of two ways, either with primary PCI or fibrinolysis. Reperfusion has been probed very well to improve clinical outcomes if done within 12 hours of the symptom onset. And the improvements over decades has been like this. Like in the pre-CCU era, the 30-day mortality was around roughly 30%. That has come down to 13 to 15% when the CCU era was instituted with defibrillation, hemodynamic monitoring, and administration of beta blockers. But currently, with reperfusion, including fibrinolysis, PCI, and CABG, the mortality rate, 30-day mortality, has come to between 5 and 6%. And this was achieved because of the various treatment modalities of reperfusion. The 1990s and early 2000s were somehow achieved by fibrinolysis, but later on, the issue was taken up by PCI. This is because, although fibrinolysis had the earlier studies have demonstrated an absolute mortality reduction of 33% when fibrinolysis was done within 6 hours, and then 2% if it is done between 7 and 12 hours, whereas, it becomes non-significant if it is done beyond 12 hours. But later, randomized trials have demonstrated even a benefit that ranges between 15 and 30%. The various substances that are used as fibrinolytic agents are tenecteplase, reteplase, and others, including streptokinase. And their performance in terms of achieving TIMI2 and TIMI3 from where like 10K achieves around 85%, TIMI2 and TIMI3 together, reteplase 84%, whereas streptokinase is limited to 60%. But overall, basal patency remains around 60%, which is quite inferior to PCI. Because studies that have meant to compare PCI and fibrinolysis, a meta-analysis of 23 of them has demonstrated a landslide clear benefit with PCI compared to fibrinolysis when it is done in the first 12 hours. Then the next issue is, if this difference exists, what about providing PCI for those individuals with failed fibrinolysis? That means a kind of combination of them that starts with fibrinolysis, and once fibrinolysis is concluded to fail, instituting PCI was considered. And one of the studies that has tried to look into it was the REACT trial, which has shown a clear survival benefit with rescue PCI when fibrinolysis fails. And then a meta-analysis of such studies has also replicated the same advantage, like MI, stroke, days, a composite of them was better with rescue PCI compared to individuals who are remaining with fibrinolysis. So then, percutaneous coronary intervention or PCI is more effective, less, and it's associated with less recurrent ischemia, unlike fibrinolysis, and it also shortens hospital stay. But the problem is it requires a lot of experience, and it is more expensive. So because of this issue, smaller infarcts, especially limited to the inferior location, in the absence of heart failure, important arrhythmias, and contraindications to PCI. In these situations, patients could be conservatively managed. Otherwise, institution of PCI, if it is done in the first 12 hours, is quite beneficial. The next important issue is the issue of door-to-balloon time. Like, door-to-balloon time is the time that the patient arrives to the hospital up to the first ballooning. That shouldn't be greater than 90 minutes. Currently, with the intention of pharmacoinvasive strategies, that is stretched up to 120 minutes. But the other conditions, like in patients with high risk of bleeding, those with demanding circumstances like shock, or if the diagnosis is in doubt, or when the fibrinolytic fails, in these circumstances, PCI should always be utilized. So now the most important thing regarding revascularization, be it chemical or mechanical, the most important thing is one has to keep in mind that time is muscle, meaning if you look at the necrotic tissue, like in 1 hour, it's very limited, but as time increases, the span of the myocardium that becomes necrotized progressively increases. So because of this, we should always be concerned about time from the time that we have contacted the patient, be it outside or within the hospital. So when it comes to the comparison of PCI with fibrinolysis in terms of time, PCI loses 1% advantage over fibrinolysis with every 10 minutes delay for PCI, waiting for PCI against fibrinolysis. So this is an important point that has to be kept in mind when one intends to administer either fibrinolysis or intervention. When cardiac survival is seen, when one compares, like in this particular study, over 2,300 patients were divided into 0 to 90 minutes, 90 to 120, and the others respectively. Survival was quite better. Cardiac survival was better when PCI was done within 90 minutes compared to 120, 180, or over 180 minutes. This is just to show you the in-hospital mortality. In-hospital mortality progressively increases as time delay increases, and that persists up to 7 years. Like, if the procedure is done in a short time compared to a delayed administration of intervention, that difference is defined to persist up to 7 years. So the optimal time, the time that it can be stretched, the time that clearly PCI becomes advantageous over fibrinolysis, is 114 minutes. That means this is the time between door to balloon, when door to balloon time minus door to needle time, that means administration of fibrinolysis. Unless it exceeds 114 minutes in hospitals with PCI facility, it's still advisable to proceed with PCI compared to fibrinolysis. The other option people have to look into is facilitated PCI. There are studies like the Ascent for PCI that have tried to look into it. This study was early truncated before it finished its plan for 1,000 patient recruitment because of landslide benefit in terms of increased days, increased heart failure, and shock with patients who were given facilitated PCI, meaning a combination of fibrinolysis and administration of PCI together. So that was not beneficial, and meta-analysis of studies, including others, was also demonstrating increased short-term mortality, increased non-fatal MI, and increased necessity of target vessel revascularization plus stroke was higher in this group of patients who were offered facilitated PCI. So because of this is now obsolete. So the other option is especially in situations like ours where PCI facility in the nearby is quite scanty, there are options like one, regardless of time, just to refer or wait for primary PCI. The other one is ischemia-guided transfer of patients. That means fibrinolysis is administered, and then when it fails, patients are transferred. And the other option is the new option, pharmacoinvasive strategy. Patients will be given fibrinolytics, like if PCI is not going to be done in a matter of under 20 minutes, we'll see it. These patients are given fibrinolysis and then immediately transferred for early PCI within 2 hours up to 24 hours. And there are studies that have tried to look into it. This is the dynamic trial that has compared repeated administration of fibrinolytics with transferring of the patients. And patients who were transferred to PCI facility, these are patients who are presented to hospitals without PCI facility. And in this group of patients, patients who were referred for PCI did better than patients who remained with fibrinolytics, even with repeated administration of fibrinolytics. And meta-analysis of such several studies has concluded that transferring patients is quite better. And when the registries, like for example, the American registry was seen, and a time gap, a time difference between door to balloon minus door to needle time up to 120 minutes is advisable to proceed with, like if 120 minutes is exceeded, that's the only time fibrinolytics must be administered, and then patients referred to a PCI center. This is because even in America, only 36% of the hospital setups could achieve this 120 minutes. So, this problem exists everywhere in the world. So in conclusion, PCI-related delays are extensive and are associated with poorer outcomes. But no differential excess in mortality, even with long PCI-related delays. So that means even this 12 hours time bound is very much blurred with PCI compared to fibrinolysis. It would be erroneous to administer a fibrinolytic beyond 12 hours, but PCI can be applied at any time whenever the patient, the issue of PCI will be decided after coronary angiography. So any individual who has developed MI must be offered cardiac catheterization. That is the understanding, the teaching today. But whether to proceed with PCI or not depends on the anatomy that we are going to obtain. And the difference between door to balloon and door to needle times, as they increase, mortality advantages of PCI obviously become declining. So let's just look into pharmacoinvasive strategy. This is one of the studies that has looked into it, recruiting over 1,000 patients. This is a transfer MI patients. Patients were divided. The difference between dynamic and transfer MI is patients with fibrinolysis, they were offered rescue PCI, classic rescue PCI. But when they compared them, patients, even fibrinolysis plus rescue PCI could not be equivalent to individuals who were given fibrinolysis and sent for PCI. So administration of fibrinolysis and immediate referral for PCI, anticipating PCI within 2 to 24 hours was better than keeping patients with fibrinolysis only offering rescue PCI. And the meta-analysis of such studies has come to a similar conclusion, like especially recurrent myocardial infarction, recurrent ischemia were better with individuals who were routinely intervened compared to individuals who were given the facility of fibrinolysis plus rescue PCI. Let's just look into what's happening when pharmacoinvasive strategies compared to standard treatment. So early PCI after successful fibrinolysis reduces 30-day mortality, and this is also accompanied by reduced infraction, reduced ischemia. These are the two important circumstances that dictate the benefit of routine PCI compared to fibrinolysis and rescue PCI. And this is achieved without significant increment in terms of bleeding and stroke. That is the most important issue, which makes it very, very important. In conclusion, PCI within 24 hours after thrombolysis in STEMI reduces recurrent ischemia, reduces recurrent reinfarction without increment of bleeding risk. Now let's compare a routine PCI with that of pharmacoinvasive strategy. There are studies like this one. This is Gracia from Spain and Portugal together. It was a small number of patients, but it was comparing even biomarker positivity and biomarker increment. You know, when they compared individuals who were transferred for pharmacoinvasive strategy with that of individuals who just got timely access for PCI, there wasn't any difference in terms of biomarker positivity, and clinical outcomes were not also different in this between these two groups in this particular, but the study is smaller, as I said earlier. The standard landmark study in this regard is a STREAM trial. It has recruited over 1,800 patients. These are patients who presented within the first 3 hours after the onset of MI, and they could not be offered PCI within 1 hour. When these patients were divided into two, fibrinolysis plus pharmacoinvasive strategy and standard PCI administration, there was no any difference between the two groups. So now, let me take you to one case. This was an individual, 42-year-old smoker, who could be given fibrinolytic in the 3rd hour after MI. And the result, when he was taken to the cath lab the next day, within 24 hours, this was the finding. Still, there is a huge thrombus, although the vessel is open. It requires intervention, and when we intervened, this was the end result. So in summary, when it comes to STEMI, we have to be able to do ECG within the first 10 minutes, and we have to settle the diagnosis of STEMI because it relies on ECG only. And then these patients, if they are not able to undergo PCI within 120 minutes, they will be offered, they will be given fibrinolytic. Like for instance in Ethiopia, if we are given the opportunity of administering at least streptokinase in hospitals where we have internists, that can be practiced. And then after administration of fibrinolytics, patient is referred. This is a table. This is a conclusion from the European Society of Cardiology. And those patients will be referred for PCI. You know, in between, at the 90-minute time, if fibrinolysis fails, patient will be urged for pharmacoinvasive strategy, I mean for rescue PCI. Immediately, that patient requires intervention. Otherwise, if the vessel opens, there will be a planned angiography within 24 hours. So we can stretch that time up to fairly, and scientifically, we can stretch that time up to 48 hours in our setting, for instance, why? Because 48 hours is a cut point for viability testing. So until a requirement of viability testing sets in, we can stretch and still administer PCI. But even then, coronary angiography is always beneficial. One has to see the anatomy and decide, because partial occlusions are very common. So, in conclusion, in managing acute coronary syndrome, particularly MI, there should be high index of suspicion, which is critically important, and early management of acute coronary syndrome requires facility with defibrillation, different medications, and capacity to detect and manage complications. That is critically important. The telephones of individuals who are managing or looking at such settings, telephones must be open, and consultations and communications must be straightforward. Modified pharmacoinvasive strategy, that means up to 48 hours, is a strategy that is applicable and advisable in Ethiopia. Thank you very much.
Okay, thank you so much, Doctor, for the presentation. Participants, if you have questions regarding the subject matter, please raise your hands, and I will allow you to speak one by one, and you can ask your question. All right. The next question is from Addis. Can you tell us, please, your experience with fibrinolytics and side effects in our setups? We have a fear of stroke or hypotension, which may not be understandable by patients in their attendance.
Yeah, my experience is not as wide as that of my experience in PCI. As you all know, these are medications that are coming, they are not coming officially. So the frequency is not that big. But I have been having some experience in the last 15 years, was in Addis Cardiac Hospital in Gizund. The only individual I remember is one who bled intracerebrally, and this one is quite recent, 2 months ago. That's the only individual. Better characterization of patients, better consideration of absolute relative contraindications would mitigate the situation. So if patient comes, especially in the first, if we happen to meet the patient in the first 2-3 hours, and somehow we are not able to institute PCI for that particular individual, unless there are absolute contraindications, we should not hesitate to offer him streptokinase. That is my experience. Because tenecteplase and reteplase, they are not very, very common. They are very sporadic. So the one which is relatively commonly obtained is streptokinase that can be administered in the way I tried to characterize the circumstance. That's my experience, what my experience states.
All right. The next question is from Lydia. What level of highly sensitive troponin is said to be high to diagnose MI? Or in other words, how many times should the troponin rise to diagnose MI?
No, it depends on the cut point of that particular assay. Somebody cannot any elevation beyond the limit must be considered seriously, because troponin positivity is the most serious matter in terms of coronary issue, because the prognostic implication, the mortality, the incurred mortality behind is so serious. So once it exceeds, the assay should be dependable. You have to choose a very good assay, and then if there is significant elevation, you should be concerned. Even there are individuals who are concerned when, within the range, if there is increment, that has some implication on its own. So any increment should be seriously considered.
Okay. So another one is from Belle Adal. What should be done if it's late or greater than 120 minutes what other options are in the case of non-available fibrolysis in PCI?
Conservative medical treatment composed of proper administration of aspirin, like the first dose of aspirin should be at least 160 milligrams. It should be chewed for immediate buccal absorption. 300 milligrams of clopidogrel should be administered, and the patient should receive unfractionated heparin. It should be available. Then patient must be offered oxygen, IV access, ECG monitoring. These are important issues, and we, the professionals, must be able to detect and treat heart failure, arrhythmia, recurrent ischemia. We should be able to detect. So in that situation, we can manage them conservatively. When I was a resident or early in my professional track, we are managing patients conservatively. It's only 15 years ago I started to do intervention, and I did not have any chance to apply it for every individual because it's very costly. So there are still patients who are managed, huge number of patients who are managed conservatively. But if the opportunity exists at any level, coronary angiography must be attempted in individuals who developed MI.
Okay, so the next one is from Amara Hailakiros, and the question is how frequent you do CABG for failed pharmacological and PCI recanalization? How do you rule out prinzmental angina for STEM without doing cardiac enzyme?
Failed PCI, you will have a very good judgment before you intervene. So the only circumstances, like if you have all the required facility, failure of PCI is not a common thing. So it's not like, for instance, in the study I was referring to from Gizund, the first 197 patients, we achieved TIMI3 in 86% of them. And when TIMI2 is added, it exceeded over 95%. And these are not individuals who are dedicated for, the remaining ones are not meant for coronary bypass surgery. This is usually with acute ST elevation MI, the no reflow phenomenon. This is what is known as no reflow phenomenon. Otherwise, failure of PCI is not that very big today. If the vessel is otherwise to benefit from intervention, it will be pre-decided that those patients will be, depending on the syntax score, they will be dedicated to coronary bypass surgery right from the start. That is a classic way of going into it.
Okay, great.
And prinzmetal angina, vasospastic angina is very, there are MIs and manifestations in the absence of obstructive lesion. Prinzmetal angina can exist both in the presence of obstructive lesion or in the absence. Coronary microvascular dysfunction is becoming an important and attractive area as well. So these are circumstances very difficult to diagnose. It requires a high index of suspicion, and we should apply. Patients who are complaining of something what looks like prinzmetal or vasospastic angina, they must undergo investigations like the ones I mentioned, functional or anatomic verifications must be carried out. If there is a lesion, those patients, significant lesion, the lesion has to be treated accordingly. If there are no lesions, medications like beta blockers, non-dihydropyridine calcium channel blockers, nitrates, and the new ones like ranolazine, which is currently available in our country, which is a late sodium current inhibitor. It reduces intracellular sodium and, in effect, intracellular calcium, which treats the demand side. It treats the angina. Nicorandil could be utilized. Trimetazidine is also available, which is a fuel-efficient anti-ischemic treatment, which means it switches from beta oxidation to glucose oxidation, which is fuel efficient, meaning in terms of oxygen, and it reduces angina. So those medications could be utilized in this circumstance if the coronary angiography does not show any obstructive lesion in the epicardial coronary arteries.
Okay, so we'll just ask 2 questions after this, and we'll proceed to the quiz section. This one is from Fiametta. So, what are the contraindications of anticoagulants in MI? And another one is, when do we use B blockers? We said plus or minus on the presentation. And when do we differ it? In other words, the contraindications of B blockers in MI.
Contraindications of anticoagulants in general. If there is active bleeding, we shouldn't administer it. But it depends on the reason of the bleeding and the location of the bleeding. If the advantage of a particular medication outweighs its drawback, you may be called on to intervene. Like I remember a patient who had pulmonary thromboembolism, and there was a thrombus in transit at the right atrium, but at the same time, patient has developed intracellular bleeding. And then, out of desperation, I acted with unfractionated heparin because I thought by then it was, it's relatively simpler to discontinue unfractionated heparin because of its shorter half-life as compared to low molecular heparin. That was why I chose it. And that patient survived somehow. So there are circumstances whereby you need to choose between 2 devils. Otherwise, if there is active bleeding, conventionally, the advantage is a kind of there one can omit administration of anticoagulation. Like in the presence of a small MI in the inferior wall, I may just dedicate the circumstance to aspirin and clopidogrel or even aspirin alone, especially in the absence of intervention. So it requires, everything cannot be put in a guideline. So it requires our judgment. And the other one was, what did you say? The next component of a question? Yeah, beta blocker. Beta blockers, there are a lot of questions on IV administration of beta blockers. In studies like the ACUITY trial, there was a lot of issues, especially related to shock. It is customary, to administer this cocktail of medications like AC inhibitors, beta blockers, and the nitrates. Then patient becomes in a state of shock. Like in the evening, when the patient develops acute MI, acute ST elevation MI, a young individual with occlusion of proximal LAD and extensive anterior MI, the initial response is increased adrenergic drive, heart rate will be high, blood pressure is spuriously high, even in individuals who are not hypertensive. Then some residents indulge with loss of the drugs I have been mentioning. And then in the morning, patient's blood pressure is so low. And then patient becomes so fatigued, even the heart failure state worsens. So one has to be careful in the beginning. You have to calm him down, administer anxiolytics, provide him with oxygen if the O2 saturation is less than 90%, and then draw his attention. Then everything settles down before moving or rushing with beta blockers. They were demonstrated to reduce, in fact, expansion, rhythm disturbance, even mortality, but those are earlier studies before optimal medical treatment has been optimized further. So we shouldn't embark a lot on beta blockers at this time.
All right.
Their administration must be safe.
Okay. All right. Thank you so much, Dr. Abakala. Before you go, if you have any last regards that you would like to mention, I give you the stage.
I am so happy when Blue Hills, with this number of audience, provides me the opportunity because as an academician, I believe it's my duty to try to educate my juniors and if possible colleagues. So that is the intention I have. And I have tried my best, and I wish you all the best.